AMAROS study is designed to see if we can de-escalate the treatment of the lymph nodes in patients with invasive breast cancer. When the trial was designed some 15 years ago, in patients who had a sentinel node and contained cancer cells, but tumor-positive sentinel node, the axillary clearance, complete axillary lymph node dissection, was standard of care. So we looked for possibilities to improve side effects, lessen side effects of the axillary clearance. And radiation therapy was one of the possibilities, and we had already some experience of irradiation of the axilla together with the breast in patients with early breast cancer. And this showed that it was effective. There were small studies, but as a background it was sufficient to start this large trial where patients with a positive sentinel node were randomized between either axillary clearance or radiation of the axilla, in general together with irradiation of the breast, because most patients had breast conservation and a radiation indication anyway. The patients need to have, of course, an unsuspicious axilla, and 60% of them had also ultrasound of the axilla, and the ultrasound need to be negative, of course. Patients were randomized before the actual surgery. So patients who were eligible for the trial were asked, okay, do you want, the axillary clearance is standard of care, but we have this trial where we compare the radiation therapy. Do you want to participate? If the patient said yes, they were randomized, and before they went to surgery, they knew on beforehand that if the sentinel node was positive, they would get radiation or the surgery. Then patients went on to surgery, they got their sentinel node, and the patients who were allocated to axillary clearance, we could do a frozen section intraoperatively, and if the sentinel node was positive, we could proceed to the full axillary clearance. Of course, this was not necessary in patients who were randomized to radiation therapy, so there we removed the sentinel node and did examination, but not intraoperatively because it has no consequences. And this is now the standard practice, actually. We don't do frozen sections anymore. So this was the design of the trial. In itself, 4,800 patients were entered, and 1,400 had a positive sentinel node, somewhat more than 1,400. 2 times 700 patients randomized to either treatment, and we presented 5 years ago the 5 years results. And these 5 year results were extremely nice and good. That is, that in the patients who had radiation therapy, the occurrence of lymph node metastasis happened only in 7. And those who had axillary clearance, it was in 4. So the number of events was extremely low, and it's much lower than expected. So the trial was underpowered for its primary endpoint to show the non-inferiority because of too few events. That's why the New England didn't take the paper, but we were able to present it in the Lancet. But it was underpowered, and another criticism was that 5 years of follow-up is too short. In this radiation group, many patients could get still metastasis later on. So these two things were the thresholds to adapt to this principle. In the Netherlands, it was embraced immediately, and in some other countries, but in many countries, people were reluctant and hesitant to embrace this possibility. Okay, now we have the 10 years results, and in the radiation group, the number of axillary occurrences is 11, from 7 to 11, 4 more, and in the axillary clearance group, it's 7, 4 to 7. Extremely low. Nothing happens after this. Virtually nothing happens after this 5 years. So this 10 years results are extremely good. The lymphedema issue remains the same, that after radiation therapy, the risk of lymphedema is much less than after surgery. So the side effects are much less after radiation therapy. And there is, of course, no difference in overall survival and in disease-free survival whatsoever. So now we're quite firm in our conclusion that irradiation of the axilla in patients who have a tumor-positive sentinel node is a good and safe thing to do instead of axillary clearance. Again, radiation of the axilla is a perfect alternative to complete axillary clearance. Of course, there's 2 trials out there in patients with early breast cancers, the Z11 and the IBCSG trial, where patients were randomized to no further axillary surgery and axillary surgery when the sentinel node was positive. And there was no difference in axillary occurrence of lymph node metastasis in both trials. We have to realize that in the Z11 trial, patients got, of course, a tangential field irradiation therapy, and if you go back to those radiation fields of patients who had a positive sentinel node and were randomized to no treatment, quite some radiation oncologists adapted their radiation field. So I have the impression that the Z11 is actually a kind of AMAROS light. So how do we use this information now to integrate in clinical practice for coming Monday or the past years? If there's very limited involvement in the sentinel node, isolated tumor cells, micromets, we do nothing. It's fine. If there is low risk features of the primary tumor, smaller tumor, grade 1-2, no lymph, no LVI, and there is only one sentinel node with a macromet, we also do the wait and see policy. If there is pathological negative high risk features, larger tumor, lymphovascular invasion, more positive sentinel nodes, we do the irradiation. So if you see in practice nowadays of patients with a positive sentinel node, in our practice about 70% will get no further treatment and 30% will get radiation therapy.